So, just a quick question.
So Dr. Chandrakant sir has been joined.
Yeah, Roshini, we can start.
Okay, sir. So hi everyone, very good evening and thanks for attending this webinar. I would like to invite Dr. Sushant Vinakar sir for setting the context and take the event forward. Sir, over to you please.
Thank you, Anita. So, good evening to all the attendees. On behalf of MPI, I welcome all the esteemed faculty of this webinar and all the attendees who have logged in. So, as part of the educational webinars that MPI has been conducting, this is the third online webinar of 2025. So, this year, along with the online webinar series, MPI has also organized hands-on workshop for training on HER2 low and ultra low scoring for pathologists. And two of the workshops have already been conducted. One was in Kolkata and one was just this month in Bangalore. So I welcome you all to today's webinar. And today's webinar is on MET alterations and expanding territory in non-small cell lung cancers. So we are in an era of precision medicine, and biomarkers play crucial role in guiding treatment decisions, especially where targeted therapies and immunotherapies are involved and are utilized routinely for patient care. So application of these biomarkers is expected to enhance diagnostic accuracy, inform prognostic evaluation, and to optimize treatment strategies in lung cancer to improve the patient outcomes and the quality of life. According to the latest guidelines that have been released, the routine assessment of MET alteration is now recommended in the routine molecular workup of advanced non-small cell lung cancer, particularly in patients who have experienced disease progression after first-line treatment. So, accurate detection of MET alteration is become an essential part of the patient selection for guiding precision medicine approaches in lung cancer. It is therefore important for the clinicians and pathologists to stay updated on the emerging guidelines for biomarker testing in lung cancers and the available new targeted therapies. So, in this webinar, we will explore and discuss on MET alterations in lung cancer. So, for this webinar, we have our first speaker, Dr. M.V. Chandrakant, who is a medical oncologist, and he would be enlightening us on the different treatment modalities available for MET alterations in advanced non-small cell lung cancers. Over to you, Dr. Chandrakant. You can start presenting your slides.
Thank you, Dr. Sushant. uh, so initially, I thought of sharing the slides from my end, but
Sir, I'm sharing the slides, sir.
yeah. So previously, from WhatsApp to email, it was easy. So now it's not easy. So whatever presentation is there in my WhatsApp. So that is a challenge. Anyways, I keep saying next, next, and you help me. Okay. So MET alterations, I mean, Yeah. So this is I think this is one of the few events where MET has been addressed. So we have had events in exon 14 skipping space, whereas MET amplification, there is hardly any event that has happened till date as far as my knowledge goes. So this is one of the first and the unique webinars which I am taking you through, focusing on MET amplification or overexpression. Okay, next slide. So this is what I'll be taking you through. What are the unmet needs? When should you think of MET? And then I'll summarize finally. Next. Right, next. Well, EGFR mutant lung cancer, when I see a patient in front of me, I'm really happy, you know, especially when they have sensitive EGFR mutations like especially when you have exon 19 or exon 21, it's very good to treat because osimertinib works long. You see a overall, I mean, an excellent progression-free survival of 1.5 to 2 years. If it is exon 19, it's much longer. But the challenge comes when these patients progress. What to do after osimertinib? That's the challenge. So there are multiple resistance mechanisms for after a third generation EGFR TKI. Among the resistance mechanisms, we usually do a liquid biopsy or preferably a tissue biopsy whenever possible, and we try to find out the reason for resistance. A tissue biopsy is more preferable because a histological transformation to small cell is also an important resistance mechanism. Next slide. So what are those uh, uh, so what are those resistance mechanisms? So you can have a histological transformation to small cell. The other resistance mechanisms are uh, those on-target mutations. For example, you have a rarer EGFR mutations which are on target, or an EGFR amplification. This is one. The other ones are all these. The post-receptor pathway. For example, a MET, an AKT P10 PIK3CA, a BRAF or a HER2 or a RAS. These are other pathway, meaning off-target mutations that happen. And among that, MET amplification is the next best targetable resistance mechanism. So, so the whole purpose in treating any driver mutation positive lung cancer is to give targeted therapy as much as possible. I want to keep them chemo free, or I want to extend the PFS1 and PFS2. So that is really golden. Like the moment the patients complete second line treatment, the survival significantly comes down. So therefore, finding out targets at each progression is extremely important. Next slide. So not only in EGFR, but also in ALK and ROS, these also will come in a big way, because even an ALK TKI, like a lorlatinib, or a ROS TKI, we have entrectinib. So all these drugs stop working after some time. It may take 1.5 years, 2 years, 3 years, but at some point of time, the cancer cells develop resistance to these TKIs. So what to do next? MET is the way to go. You need to do a tissue biopsy preferably and look for all types of MET mutations, MET amplification or overexpression. Next. Yeah. So what are the different types of MET mutations that we look into? So one is exon 14 skipping mutation. That's seen in the first line. I mean, usually in treatment naive setting, that's not a resistance mechanism usually. But a MET amplification or a polysomy is something that's crucial that results in MET overexpression, and this is the resistance mechanism for TKI. The already available drugs like capmatinib and also tepotinib, they are basically designed for exon 14 skipping mutations. Next slide. So MET is also found in RCC and other papillary RCC and so on. So MET is basically mesenchymal epithelial transition. That's the full form of MET. And you can clearly see that MET is a resistance pathway and there is a crosstalk between EGFR and a MET. So when a patient progresses on an EGFR TKI like osimertinib, MET becomes a resistance pathway. Therefore, inhibiting EGFR along with that, adding a new MET inhibition would be an attractive way. Next. Right. So in the era of first and second generation TKIs, T790M was the predominant resistance mechanism. But when I'm using osimertinib, which is specifically designed for T790M, there you don't see T790M as the mutation, as the resistance mechanism, but MET becomes predominant here. So MET, especially after a third generation TKI like osimertinib, MET becomes important and you must pick it up. Next. So let's see the newer therapies that we have. Go to the next slide, please. Yeah, let me take you through the Savannah study. It is a MET inhibitor, savolitinib plus osimertinib in patients with EGFR mutant non-small cell lung cancer and MET overexpression and or amplification following progressive disease on osimertinib. Next. So I gave osimertinib. On osimertinib, they have a MET mutation, overexpression or amplification. And they use different cutoffs like 50% positive or a fish 5 and so on. And they try to find out what is the best dose of savolitinib along with osimertinib. Next. There were some different versions of 1 to 6 and the protocol was revised to version 7 and they looked into a dose of 300 milligram twice a day. And they wanted to find out the RP2D, I mean, the tolerable dose in the phase 2 trial. Next. So then they looked, initially they looked for a MET IHC of more than 50% and a fish of 5. And later on, they looked specifically for a subset of MET IHC more than 90% and fish 10, the ratio being 10. So they looked into this and they looked how osimertinib plus savolitinib is effective in this particular subset. Next. So there you go. You get a progression-free survival of 7.4 months. So just to give you a perspective, in a first-line setting, you would get around 1.5 years of PFS, and adding 6 more months of PFS, a chemo-free interval matters in these MET amplified or MET mutated patients. Next. Well, exon 14 skipping is more targetable, much more easier than an amplification or a overexpression, which I was showing you. Just I want to bring in 3 molecules, which we have been using in practice. I've used capmatinib. It does well. You get a good PFS of over a year. And you have tepotinib. So capmatinib was from the geometry study and tepotinib also, we have the vision study. Both have been well. The class side effect is edema. Edema is the class side effect of these drugs. We have used these in these patients. They give a modest PFS and they work specifically in the exon 14 skipping space. And they're not designed for amplification. In amplification, they don't act that well. They look for gene copy number more than 10. I mean, probably in that subset they I mean it's not promoted in that way, or it's not active in that way. It's mainly for exon 14 skipping. And then the other molecule I use is amivantamab. It's both a EGFR and MET inhibitor. In the present day post osimertinib, if there is no target mutation in the liquid tissue, I use amivantamab chemo as a standard of care. And then the other one is which I am seeing is telisotuzumab vedotin. It is an antibody drug conjugate in a c-MET positive patient. It is not an EGFR mutant population. It's wild type EGFR. So these are some attractive targets that are going to come in future. But as of now, tepotinib, capmatinib, and amivantamab. These are some MET inhibitors that we can use. And off-label, we at times use cabozantinib also. Next. So these are the trials that I was telling you, not much mature. Tepotinib has shown some mature data with around 5 months of PFS. Next slide. Right, let me summarize. So, EGFR, ALK, ROS, MET exon 14 skipping was well recognized as a targetable mutation. MET amplification is a tough, it's not as easy as exon 14 skipping to target. But now, because we have a drug and we have a trial addressing this, giving a PFS of 6 months and above, uh, uh, and having this benefit, it is important to pick up MET amplification, especially in patients who have a EGFR mutation or even ALK or ROS, which I showed in those slides, because this is one of the most important resistance mechanisms in almost 1/4 to 1/3 of patients. So we must do a MET testing. So the definitions I just showed there. And then if you can pick them up and you can give them targeted therapy, you will get a median PFS of 6 more months or even more than that. And you can keep the patient in a chemo-free regimen. So if we use more frequently, and we will get to know the hands-on experience of this drug. So the Savannah study has been sort of attractive and probably will be practice changing. So nowadays we don't look for amplification because we don't have a drug. So when we have a drug, we will start looking at amplification as an important target for treatment. Thank you again for all of your patient listening and looking forward for presentations and panel discussion.
So, thank you, Dr. Chandrakant. So, Dr. Chandrakant is a leading medical oncologist in Calcutta from Narayana Hospitals, Howrah. And based on his experience, he's been routinely using the targeted therapy for MET. And based on his experience, he shared the recent updates that are available on targeted therapy front for MET alterations. So after Dr. Chandrakant's session, we move on to how we are supposed to test for the MET alterations. And this is very important and critical part because based on the biomarker testing for MET, the treatment decisions are taken. So for this talk, I would invite Tasneem Habib, who is Global Medical Affairs leader, diagnostics for AstraZeneca. And Tasneem would be speaking on the practical applications and challenges of MET testing in metastatic non-small cell lung cancer. So over to you, Tasneem.
Thank
Please
you so
start
much.
your presentation.
Thank you. I'll share my screen. Good evening, India. Let me share my screen. And then... Okay, super. So thanks for that lovely introduction. I'm Tasneem Habib, and I'm the Global Medical Affairs Leader at AstraZeneca, global headquarters based out of US in Gaithersburg. So let's take a look at the practical application and challenges for MET testing in metastatic NSCLC.
Name, sorry to interrupt, your screen is not shared, I suppose.
Is it not
We are not
sharing?
able
Okay.
to visualize your slide decks.
Okay, let's give it another go then. Okay. Can you see let me know if you can see my screen now. Is that better?
No, it's not yet come.
Okay. Technical glitches. Let's have another go.
Yeah, it's something is
Yeah,
coming up now.
Tasneem, now,
Okay, perfect.
yeah,
It's clearly
now you
got a
can
long
do
way.
the, yes, you
Yeah,
can do the slideshow.
thank you.
Yeah, now we can see your screen.
Super. Yeah, it's clearly got a long way from the US to India to travel, so a bit of a time lapse there. So let's talk about the practical application and challenges of MET testing. So thanks for that fantastic overview and setting the foundation for MET testing. So MET testing has been around for a number of years, and as we've seen in the previous presentation, it really has been about MET exon skipping 14, and that's NGS testing. But the dynamics for MET testing is changing now because we've got a number of evolving drugs and new biomarkers that we're testing. So let's take a look at MET in detail. Next slide, please. Oh, sorry, I'm kind of controlling my own slide, sorry. So MET is really a cell membrane tyrosine kinase receptor for HGF, and the pathway is really, really critical in terms of cell proliferation, survival, embryogenesis, and cellular migration. And we know that aberrant activation and MET signaling pathway has been implicated in oncogenesis. So in essence, MET is really important in terms of tumor progression. So how does MET amplification how does it increase MET receptor protein and therefore resistance? I know we had a really beautiful slide in the previous talk that covered how MET amplification and how it bypasses the crosstalk with EGFR TKIs. But let's take a look at this slide in a slightly different scenario, looking more specifically at the gene and the testing piece. So we know that the MET gene resides on chromosome 7. And when this gene is amplified, it's duplicated on chromosome 7. We can identify this through the FISH testing mechanism, which is readily deployed in laboratories today. And we know that when we have an increased MET amplifications, that's increase in MET gene, increase in MET amplification, that leads to an increase in MET receptor expression. So what we're looking at is overexpressions, that's MET overexpression. And as you can see here, what happens is that the MET receptor expression increases, and therefore this bypasses the TKI EGFR signaling on the right-hand side, and therefore creates resistance. So the beautiful work that a first-line osimertinib, for example, is doing in preventing tumorigenesis is inhibited by MET overexpression. So what we need to do then is, in essence, block these MET receptors with the target, which is savolitinib, and that's been shown in the Savannah and Saffron trials. I'm just going to, sorry, Sugandha, or maybe someone can comment. Can you actually see the title on my slide? Because I know I'm showing my screen and it's kind of covering some of it, but
We
Yes,
can see Tasneem.
yes.
We
you
are
can see it
able to
fully.
see
Okay.
your full slide.
Okay, good. That's great. Just making sure that you can see the full glory. So there are 3 distinct types of MET aberrations in resistance, but as we've seen, we know in resistance, the last type, which is MET mutations, such as MET exon skipping 14, is very, very rare in resistance and that post-first-line osimertinib treatment patients. What we're looking at here is when you do have resistance to first-line osimertinib or third-generation TKIs, you're really seeing MET overexpression and MET amplification, and this involves a different testing technology that needs to be deployed in laboratories. Now, MET overexpression, as we've seen in the previous slide, is protein receptors that are overexpressed on the cell membrane. And to be able to identify MET overexpression, we need to deploy IHC, immunohistochemistry. In terms of MET amplification, this is, as we said, is an increase in MET gene copy numbers, which can, in essence, lead to protein overexpression. And this can be detected via FISH, fluorescence in situ hybridization. Now, we've had a lot of questions whether NGS can be used to identify MET amplification. And And what I can share with you is that at the moment, we are trying our best to get some data, concordant data, to see if NGS can be used. But to date, we are suggesting that FISH is the only method for amplification, because I'll show you later on that we are missing some patients if we use NGS. But of course, IHC is our primary testing method. And again, I'll cover that shortly with you. So these are the two key testing methods that we should be deploying now with these new targets and new drug being available. Whereas MET mutation, MET exon 14 skipping, which is already established in clinical practice and is in current clinical guidelines, is not so relevant in this resistance setting. So let's take a look at the prevalence. So what actually are we talking about when we talk about prevalence of MET overexpression? So what we've seen is that MET overexpression has a prevalence of 29% in EGFR mutated patients who have progressed on first-line, third-generation TKI. So this data has been taken from the Savannah study, which is a phase 2 study, and we had high-level results already released. It's out there in the public domain. And we've seen around about 25% generally MET overexpression present in NSCLC, but we're seeing a lot more in the Savannah study where patients progress first-line and third-generation TKI. And as covered earlier on, MET overexpression is really the activation signaling of MET or HGF, which leads to protein overexpression. And we know that the testing mechanism to identify those protein receptors is IHC, immunohistochemistry. So we're going back to basics. Immunohistochemistry is the bread and butter of pathology, and this is where we're going back to. Now, some really, really important guideline update that took place a couple of months ago. The NCCN Guidelines version 4 2025 has now recommended MET-IHC to be deployed in NSCLC patients at some time during progression. And this probably validates that it is absolutely critical that we incorporate MET-IHC into our testing guidelines to ensure that patients get the right treatment. Again, this is just a snippet of the NCCN guidelines. You can have a look at this online if you Google it, but this is actually an image from the guidelines itself. And you can see on the right-hand side and the left-hand side the previous version and then the updated version. Now, I am going to cover the Teliso-V approval here. So Teliso-V is an ADC supplied by AbbVie, and they are actually targeting EGFR wild-type patients who have MET overexpression. So you can see that a number of pharmaceutical companies out there are now looking at MET overexpression in a number of patient populations. But thankfully, because of Teliso-V's approval, we've now been able to have this updated in NCCN, which is a great story for MET overexpression across the board in NSCLC. And you can see that c-MET, MET-IHC is listed as recommended at some point during progression, and that time should be balanced with tissue conservation. Again, that's just an update. So again, here you can see the update on the right-hand side. The cutoff here that's listed is at 50%. And we'll talk a little bit more about the cutoffs for MET overexpression shortly. But there will be two different cutoffs in the future. Again, the last page here, very clear, Teliso-V, c-MET, MET at 50% IHC 3+ intensity, and that's in EGFR wild-type patients. Okay, perfect. So we talked a lot about MET overexpression, IHC, which is absolutely key. So let's take a look at MET amplification. So MET amplification has a prevalence of 20%, so slightly lower than overexpression in IHC, and EGFR mutated NSCLC patients post first-line, third-generation TKI. So this again was taken from the same study that I showed earlier, from the Savannah study, the phase 2 study. And what we saw here was that when FISH was deployed, it identified 20% of MET protein amplification. And this is the background as to why we're deploying IHC and then FISH second in the testing pathway for Savannah, potentially Saffron in the future. So MET amplification can be tested by using FISH and of course NGS, but we know that NGS in this situation does miss patients, but more data to come on that in the future. So high-level MET amplification has been listed as an emerging biomarker in ASCO and NCCN guidelines, but we know that as we develop our products and we go into market and there's clinical utility for these therapies, these biomarkers will then be upgraded to actionable biomarkers. So we should see this as an actionable biomarker in the next 6 to 12 months. So let's take a look at the actual cutoff. So approximately what proportion of patients that are progressing on osimertinib are expected to have this driver resistance. So if you take the whole patient population full of NSCLC patients that are unselected, you then get patients that have been selected for MET, IHC, and FISH. So again, this is data from the Savannah study. So what we did here is that we looked at patients that have IHC overexpression or MET amplification via FISH. Now, initially, as the previous presentation walked us through beautifully, is that the initial protocol for Savannah looked at a 50% cutoff. We recruited patients who had IHC greater or more than 50% at IHC intensity of 3+, and FISH at 10 more gene copy numbers. And what we know is that 62% of those patients were positive at that cutoff, at that 50% cutoff with 5+ gene copy numbers. What we also saw was that patients who had IHC, who were positive with IHC 90% or FISH 10+ gene copy numbers, there was a lot less patients, but they had better efficacy. So what we were finding is those 34% of the patients had better data in terms of efficacious data to savolitinib and osimertinib in the Savannah trial. And this is really key to understand why we went with a high cutoff at 90% and 10+ gene copy numbers. Because of course, we want patients to have the most optimum chance and better survival with the therapies that we prescribe. Of course, at the lower cutoff, you can see there's a lot more patients that you'll be recruiting and that will be eligible for therapy, but that's not what we wanted. We wanted to get better efficacious data. Now, let's take a look at the Venn diagram on the right-hand side. So you can see here that IHC positive patients and FISH negative were 14%. 15% were actually both IHC positive and FISH positive, whereas IHC negative and FISH positive were 5%. Now, this is really key to understand why we've gone ahead and we would like to focus on IHC testing first, because it's that 14% of patients that we want to identify. Now, if you're positive, you're great. Potentially, you could be put forward on MET-targeted therapy. But if you're negative, we really want to catch that 5% of patients who are actually IHC negative but FISH positive to make sure that every patient is getting the optimal chance of being prescribed a MET inhibitor. So for that reason, we are looking at IHC first, and then if it's negative, you then go on to a FISH test. And you can see that the FISH prevalence is at 20%, whereas IHC in total is 29%. So FISH is again slightly lower sensitivity there, and hence why IHC is our first test to be deployed in this situation. So again, just a bit more data. We love data in diagnostics. So to really kind of understand why we've gone with IHC and FISH and not NGS. So we've had a number of previous studies that have deployed NGS in our Orchard study, the Elias study as well, which really focuses on the 24% MET amplification prevalence via tissue NGS, whereas in the Elias study with plasma being incorporated, we were looking at 17% MET amplification. So you can see the prevalence being much lower. Whereas on the right-hand side in the Savannah study, the phase 2 data we've got there really kind of focuses on the 34% prevalence with both MET, IHC, and FISH. And this is why we've gone with both tests for potentially Savannah and Saffron. So let's take a look at IHC and FISH. So those of you that are from the pathology lab probably get quite excited about IHC, because I definitely do. IHC, as we said, is really the bread and butter of pathology. It's been around for a number of years, and it's a really, really simple test, but yet it's so powerful. So IHC in immunohistochemistry It can be provided by a number of diagnostic companies, but the companion diagnostic test that was deployed in the Savannah and Saffron studies was with the Roche Fontana benchmark platforms, and it's the IHC SP44 clone supplied by Roche. So the cutoff here that was deployed, as you've seen on the Protocol 7, we decided to stick to the 3 plus 90% cutoff because it was better for patients. And it's at 29% prevalence if you're using the entire kit. When we say the entire kit, it has to be for a CDX or companion diagnostic test to be a CDX. You really need to have the same platform and the same IHC clone that was deployed in the clinical trials, and that's what was deployed. We know that if you switch the instrument out, if you use another third-party instrument such as Dako and Leica, which are also in the market, you could get varying stains if you combine that with the SP44. But again, as we go into this new era, concordant study and data with alternative platforms such as Leica and Dako will be delivered because we want to make sure that optimal options are provided to laboratories, because we understand that not every lab would have a Roche instrument. So, we want to make sure that the results are comparative with other platforms as well. Now, in terms of MET amplification, again, the partner that we partnered in the Savannah and Saffron trial was with Abbott Molecular, who provide the FISH probe kit. And again, the cutoff here was at 10 plus gene copy numbers. So we've talked a lot about our testing modalities, but again, just to kind of lay them all out here on a single slide, and let's have a look at some of the advantages and the challenges that come with each technology. So the first one is, of course, IHC that we've got a big focus on here. IHC it's great. You can see that I'm definitely an advocate and going back to basics with IHC. It's very decentralized, and this is why I really like it, because it means that you've got equitable access for all patients with IHC. A lot of the labs have IHC today, whereas the more molecular technologies such as NGS can be quite limiting. You get a relatively quick turnaround time with IHC, between 2 to 4 days, whereas with FISH and NGS, you are looking at a lot more turnaround time, sort of 7 to 14 days on average. In terms of challenges for IHC, there's not a great deal of challenges like I've mentioned, because it's quite a straightforward test that you deploy in laboratories, and the platforms are quite easy to run as well, and there's very limited barriers in terms of reimbursement because the costs are very little with IHC testing. Now, one of the challenges that I am going to sort of highlight is, as I've mentioned on the previous slide, is really the platform variations that you get. So we know that you've got a companion diagnostic with Roche, but we know that you've got other platforms in laboratories as well. So we need to get robust data in terms of concordance data with other platforms to make sure that other platforms can be used. But once we've got that data, really there is no challenges with potentially using IHC. Now, in terms of FISH, now the advantages of FISH versus NGS, because FISH identifies amplification like NGS. It is more sensitive to NGS. We've seen on the previous slides from Orchard and Elias that FISH identifies 20% of patients, whereas with NGS you are looking at sort of around about 14 to 15%. But the challenge with FISH is that you need a lot more training, and you need to be sitting in a dark room. There's some training in terms of interpretation. It's not really decentralized. And when I say not really decentralized, it's not as decentralized as IHC. And it is labor intensive, but I guess it's not as labor intensive as NGS. So FISH, I guess, is a bit of a middle ground between IHC and NGS. The turnaround time for FISH is a little bit more than IHC, but it's definitely less than NGS. Now, in terms of NGS, definitely an advocate for NGS in terms of comprehensive genomic profiling for patients, which is what we want for NSCLC. We know we've got a number of actionable biomarkers now, but I believe that every test has its own place. And NGS has absolutely got a space in NSCLC where you want to identify all those biomarkers to see which potential biomarker is actionable. So a small amount of tissue can identify up to 10 biomarkers or more for a patient. So that's absolutely a critical advantage for NGS. However, we know that in this situation for MET, overexpression amplification, there is limitations with NGS. We know that ctDNA NGS, that's plasma, liquid biopsy, is associated with low sensitivity compared to tissue NGS. But even tissue NGS has low sensitivity. So in this space, NGS is probably not as suitable, definitely not liquid biopsy. And tissue NGS is definitely less sensitive, but we'll see if we can, get some data as we go into this space to see if we can use NGS in the future. But for today, we are saying that NGS is probably not the preferred testing solution. I just want to cover off the piece about liquid biopsy in patients who have just progressed on, say, first line, so the third generation TKI in that first line setting. They are very sick. So we know that there's going to be a lot of challenges with getting tissue from patients in that second line setting. So we do understand that ctDNA, could be presented as an alternative sample type, but we want to be able to share with our HCPs that there are limitations with sensitivity with liquid biopsy. So let's focus on NGS a little bit more. So there's a lot of data out there comparing NGS MET with FISH and IHC. And this table, it shows this beautifully in terms of, how we're missing patients with NGS in that MET space. So you can see you're missing almost half of patients with FISH and the same for IHC as well. So, and that's not what we want. We don't want to miss half the patients for eligible MET targeted therapy. And we can see that the prevalence for MET NGS in this quoted reference is around about 15%, which is much lower than 20% for FISH and 29% for IHC. So I've touched a little bit about tissue and the importance of acquiring tissue from patients. So, let's talk about this a little bit more in detail. We absolutely need good quality and good quantity of tissue from a patient, because without the tissue, we will not be able to do this testing, IHC and FISH. And we know that tissue is always the issue with patients, especially in that second line setting. We know that even if you attempt to get a tissue biopsy from patients, there's a failure rate of 10 to 20% just because there's insufficient quantity and quality that was acquired from the patient. And then most importantly, some patients just simply refuse as well, because they just say that, we don't want any more invasive procedures. We just want to get a treatment that does not, require a second biopsy. So, we need to keep these considerations at the top of our mind. We need to make sure that we kind of work with an MDT approach to ensure that the medical oncologist can convey the benefits of acquiring tissue from a patient, and maybe explaining the benefits of precision medicine, how a tissue can identify resistance mechanisms, which means that you will be potentially, eligible for future better treatments as well. And I think maybe explaining that to a patient can kind of increase our tissue biopsy rates as well. But really, tissue rebiopsy is absolutely critical to identify resistance. And of course, as the previous presentation touched on, we really need that tissue biopsy to understand if there's been a small cell transformation. And you can only identify NSCLC transformation through histological confirmation and diagnosis. So like I've said earlier on, the last point was really about liquid biopsy. Liquid biopsy cannot be used for pre-screening because patients will be missed. So let's have a quick look at MET exon 14 skipping alterations very briefly, because this is not really relevant in this space. MET overexpression amplification, it's all about IHC and FISH, whereas MET exon 14 skipping alteration in this resistance setting, there is a very low prevalence, around about 3%. So we're not going to focus much on this, but I do want to cover it just for completion. So we are seeing that MET exon 14 skipping alterations is really kind of present in older age, people that are smoking and an advanced disease. And we know that patients have a very poor prognosis who have this mutation. And the prevalence is more common in patients with PSC in approximately 22 to 31%. But even though, having said that, in the resistance setting, it is very, very rare, as low as 3%. It is mutually exclusive. with other genetic alterations. So it means that you'll either have one or the other. That's with EGFR, ALK, or ROS1. You wouldn't really get MET exon 14 skipping in concurrent with EGFR, ALK, and ROS1. So looking at the mechanism again, so MET exon 14 skipping alteration is really an alteration, and it's an exon or intronic region causing a deletion of exon 14. And this is why NGS testing is deployed to identify that mutation. And that's the only way you can identify this alteration is by NGS testing. So they're very unique, compared to MET overexpression and amplification. Now, MET exon 14 skipping alteration, as you've seen on the previous slides and the previous talk, there's a number of drugs out there already that target MET exon 14 skipping. And so therefore it is an actionable target and it is included in most testing and treatment guidelines. So yeah, I think that covers that. So NGS testing for MET exon 14 skipping only. So let's go back to MET overexpression and MET amplification. So I just wanted to kind of call this slide out because as I've talked about IHC in fish, I'm sure the pathologists and the lab directors on the call today are probably thinking about HER2 and how, we're kind of going back to basics when HER2 was established probably almost 20, 30 years ago. I think now I'm showing my age. But yeah, there is a lot of parallels with MET overexpression amplification with HER2 testing in the breast space. Now, in the breast space, we know that with HER2 testing, you do your IHC test and then you deploy a FISH for confirmatory testing. Usually if it's equivocal, a 2+ score on IHC would then make you go forwards to do a FISH testing. And if you're FISH positive, you're then eligible for HER2-based therapy. But if you're FISH negative, you're not eligible for therapy. There is some similarity in the IHC in FISH is deployed in the MET setting similar, but it's not identical. Because I've talked about earlier on, we're not using FISH as a confirmatory test. We are using FISH to identify any patients that are IHC negative. So if a patient is IHC negative, you are then going forwards into a FISH test. If it's IHC positive, you do not need to confirm with a FISH test. So I've covered quite a lot today. But in summary, my key points I wanted to highlight is that tissue IHC followed by FISH, if IHC is negative, is the most effective way of identifying MET overexpression and amplification. If that's one message you take away from this webinar, please do take away that first one. Now, in terms of MET overexpression amplification, we know that the prevalence, if both tests are used, it's 34% in EGFR mutated patients who've progressed on third generation TKIs. And then data suggests that NGS tissue does fail to detect approximately 50% of cases. So you will be missing patients if you're deploying NGS tissue, and you will be missing further patients if you are using liquid biopsy as a sample type, and it should not be used as in this situation. Now, tissue rebiopsy is critical, as you can tell from my previous slides. So every attempt should be made with a patient in MDT setting to acquire that tissue in optimal quantity and quality for successful MET testing and reporting. And that's it for my presentation. I'll look forward to your questions in the panel discussion. Thank you.
Thank you, Tasneem. Thank you for the excellent session highlighting the MET alterations, the updated guidelines, and the different testing modalities, and giving us the prevalence of MET alterations in the advanced progressed non-small cell lung cancers. So now the session is open for question and answers. I would request all the attendees to post their questions in the question and answer tab that is there below, written as Q&A. So now that we have seen the management of and use of targeted therapies for MET alterations by Dr. Chandrakant, and an elaborative presentation from Tasneem showing how to test the MET alterations. We will move our discussion further and we will have a panel discussion on this subject. And for panel discussion, I would invite Dr. Milab Shah to moderate this panel discussion on MET alterations and the expanding territories in non-small cell lung cancer. So Dr. Milab Shah is a oncopathologist from Yashoda Hospitals, Hyderabad. So Dr. Milab Shah, over to you. And for panel discussion, we have panelist Dr. M.V. Chandrakant would be there, who is a medical oncologist. Dr. Meenu Angi, who is a cytogenetist from Unipath Specialty Laboratory, Ahmedabad. We would add Dr. Divya Mida, who is an oncopathologist from Tata Medical Center, Kolkata. Dr. Aruna Nambirajan would be there, again an oncopathologist from AIMS, New Delhi. And I would be joining as a molecular pathologist for the panel discussion. So over to you, Dr. Milap, for the panel discussion.
Good evening, Dr. Shashank, and thanks for giving the opportunity. So, just a moment, I'll share my screen. Yeah. Yeah, it's visible.
Yeah, it's coming. The screen sharing has started, but the slide deck is not visible. Yeah, now we can see your slide decks.
Yeah, it's visible now.
Yes. Can
Yeah.
you go to the slide show so that we can see the whole screen of the slide?
Yeah. So, good evening, everybody. So now we have seen the how the molecular testing has evolved and the
Sorry to interrupt. Can you
Susan.
do slide show?
1 minute. It's on the slideshow mode only. 1 minute.
Okay, we are not seeing it as slideshow.
So previously it was working like
Okay, 1 minute.
full screen presentation mode. Or else, shall I ask IIO to project the slides, sir?
1 minute. It's visible now. It's on the full screen mode now.
What I would suggest is to stop sharing and start resharing once, because we are not able to see your slideshow presentation mode.
1 minute.
Sir, could you kindly click the from current slides? You can see the second tab, the orange color button.
Now it's visible.
No, sir, it is not yet come. I think there was a suggestion from somebody to start from current slide.
Yeah, 1
So the second tab, you can see just from current slide.
Now slides are moving now. Oh,
No, the slides are also not moving. We are on the first slide itself.
Sir, can I ask IIO to share the slides if it is okay to you?
one minute.
Or is it possible to stop sharing and then restart the sharing once, Dr. Milap?
Yeah, will do.
Sir, can we help you from our end?
Yeah, please.
Yes, sir. The slides visible now?
Yes, now the whole presentation is visible.
Yeah.
I
Now,
think,
okay.
Dr. Milap, you can start now.
Yeah, thank you. So sorry for this trouble. So we'll start with the real life scenario. So
Sir, if you could address the next
um,
slide, I
yeah, yeah,
could
yeah.
change.
Now it's me. So now we have a real life case just we come across, I think 15 days back. So that's a 48-year female diagnosed
Sir,
with the,
Milap sir, sorry to interrupt. So,
yeah,
Roshni is projecting the slides, so you
okay,
can prompt her to go to the next.
okay, no problem.
Okay. So go to the next slide, Roshni. Yeah, we are at case report, sir.
Yeah, correct. Yeah.
Okay.
So just recently we came across one case. Now that's a very common scenario for the medical oncologist. So 48-year female diagnosed with a lung adenocarcinoma. Patient at the initial in 2023, the molecular testing shows the EGFR exon 19 deletion is there. So patient was put on osimertinib, and now if you see that the PET scan report after starting osimertinib of the 6 months, if you see there is a complete response and the tumor activity has disappeared on the PET CT. But unfortunately, what happened in the recent PET 2025, the tumor has progressed. So and the biopsy currently also shows the adenocarcinoma. So it's a previous also diagnosis is also adenocarcinoma, and currently also it's a adenocarcinoma, and it's not showing any small cell transformation. So my first question to Dr. Chandrakant, sir, how do you want to intend to go proceed or with the further treatment for this patient, and how does the MET fits in the current guidelines, sir?
Right. Thank you for the question, sir. Definitely, I would want to do a rebiopsy. Whether tissue or liquid, this is a debate, but I would prefer both. So if a patient agrees for both, I would perform both tissue and liquid. And the real reason for tissue is to rule out a histological transformation and also to pick up a mutation like MET, which is often missed in a liquid biopsy. And liquid biopsy, because of the heterogeneity, because it will reflect the overall picture. So as per the target which I have, whether it is MET or any other rare EGFR mutation or a P53, I will decide my further treatment option. So rebiopsy is what is the next steps. So
Dr. Milap? So, Roshni,
Yes, sir.
I think we have lost Dr. Milap.
Yes, sir. Yes, sir. We have texted to rejoin, sir.
Sir, he just called me. There is some disconnect happened. He will be joining back in few seconds.
Okay.
Yeah. Sir, meantime, I request you can take some questions, sir, like to Tasnim, if at all any questions are there from the faculty or from the audience.
Yeah, I'm looking at the questions itself. So we have around 8 questions that are there. So I think I will start from the first question, which is by Daphne. Please, could you suggest the clone and platform to be used for IHC? I think Tasneem can. I think Tasneem has already answered the question. So
I'm just typing away. Yeah, I can cover it verbally as well. So I've
yeah,
just
so
typed.
Tasneem. Yes. So IHC clone. It has been asked by Daphne.
Yeah, sure. So I'm going through all the questions that are open and typing them out so everyone can see them. But of course, I'm happy to cover this verbally as well. So in the Savannah and Saffron trial, Savannah the phase 2, Saffron that's ongoing phase 3 trial, patients were enrolled and identified using the companion diagnostic assay from Roche Ventana. So that's the benchmark platforms that they supply, and it's the clone antibody called SP44. So that was for the IHC overexpression. And then for MET amplification, the FISH test was deployed, and that FISH test was sourced from Abbott Molecular. And both of those tests will be the companion diagnostic tests for Savannah and Saffron. Thank you.
So Tasneem, over here, I have a question since we are talking about IHC and this clones. Met alterations as of what I know have been started since they have come in guidelines since 2024. Met exon 14 was the first alteration that was included in NCCN guidelines. Then it went on to documentation as emerging biomarkers and Met amplification. High amplifications came up. And now, very recently, Met IHC has been included, which would be actually looking at overexpression. So, I mean, you have said SP44 clone on Ventana platform, but these are still in clinical trials, right? I mean, the results are from clinical trials. So, is it that we are supposed to use SP44 on Ventana platform, or any other clone can also be taken up? Because I see there are multiple other questions on Met IHC that are there.
Yeah, absolutely. So what we like to call out, like you've just said, these are still clinical trials that are ongoing, and you always get a companion diagnostic test in a clinical trial. So in a real world setting, ideally you'd like to mimic or copy the same setting because you're identifying that patient population. However, we know that in the market, not every laboratory will have a Roche instrument or have availability to the FISH platform. So, other tests can be used from other companies. I know that DACO, potentially there's another China clone out there that's for MET overexpression as well. I think in these scenarios, you'd probably just want to do a concordance or a quick validation in-house to make sure that, you're scoring at the right intensity, because of course, if you're using another antibody, the intensity might be quite different to what the Roche antibody is. So you have to make sure that you're kind of matching that. Because of course, if you don't match that intensity, not scoring appropriately, then you're identifying the wrong patient population. And in essence, that therapy may not work for them. So like I said, it is Roche and Abbott that we partnered with. However, you can use other tests, other IHC MET tests, other FISH probes, as long as there's data to support that they're concurrent and concordant.
So Dr. Milap Shah has joined in.
Yeah.
So, I mean, we can go over to the panel discussion.
Yes, extremely sorry. Now, can you move the slide to the next question? Okay. So this is to the Dr. Divya and Aruna, both are from the Premier Institute, and one is from the eastern side of the India, and one is from the AIMS, New Delhi. So what's your experience, ma'am? So have you recently come across any clinical inquiries about the MET over amplification or overexpression testing in a lung cancer?
Yes, good evening, everyone. Yes, we do perform MET amplification routinely. We've been doing it for the last 1 to 1.5 years. So the requests primarily come in the post-TKI biopsies. So particularly, here the protocol is that when the patient progresses on EGFR TKI, first they undergo a liquid biopsy, and if T790M is detected, of course, this is the pre-osimertinib era. So at that time, when T790M is negative, then only a liquid tissue biopsy is done. And on the tissue biopsy, we started testing for fish. We use fish and we report MET amplification. And now again, so we do that routinely in all our post EGFR TKI biopsies. As far as MET IHC is concerned, so that is new. We haven't received any request as yet.
Okay. And anything your experience or you want to start IHC testing by the
Hello, Milap. Divya here.
yeah,
I think we have a similar experience at Tata Medical Center in Kolkata. Uh, the requests predominantly come for MET amplification, and the samples are sent to the cytogenetics laboratory for fish testing, and also for NGS for the point mutations or 14 exon skipping mutations. So MET overexpression and IHC testing, as Tasneem said, is bringing us back to the basics. Whenever I think I'm losing my job, I seem to get my job back. And it's exciting to see that we are going in the same direction as HER2. So we look forward to the results of the trial and to the drug. And as soon as the drug comes in, we know we are going to be flooded with requests for IHC. But of course, the question will remain on certain limitations, platform, standardization, scoring methods, heterogeneity, all those issues we will look into it once we get into the business of MET IHC.
Okay, so currently MET amplification is done by the fish, and actually right now we are not using. So that's the correct.
Yeah, so fish for MET amplification is being used since a long time. Sushant, if I'm not mistaken, for the past more than 2 years, isn't it? 3 years. What is the duration, Sushant?
Yeah, so basically, we have been at Tata Medical Center. I would share the experience. To be frank, before coming for this meeting or webinar, I was not aware that MET IHC has come into guidelines, and we are supposed to do MET IHC for documenting the overexpression. So this is my experience, I would say. This is a learning experience for me. At our center, what we practice is since 2021, we have been doing NGS and FISH. So NGS we are using for MET exon 14 skipping mutations as well as for MET amplifications. And FISH is again used for MET amplifications. So we were not actually looking at overexpressions. We were looking at two alterations of MET, that is MET exon 14 skipping mutations by NGS and MET amplification by both FISH and NGS. So our practice at our center has been that uh, the lung cancer cases at the time of their diagnosis, whether they are advanced stage metastatic lung cancers or they are progressed, we are doing NGS. It's a broad panel that is there. It's an RNA-based sequencing and a DNA-based sequencing that takes place on NGS. The RNA-based sequencing also detects the MET exon 14 skipping variants, and the DNA-based sequencing detects MET exon 14 skipping as well as the mutations within MET genes. So Additionally, based on the DNA sequencing, we are able to call MET over amplifications or amplifications, sorry, or high amplifications based on the copy numbers that are there. And our practice has been, if we are detecting these amplifications, we ask the clinicians to go ahead and do FISH testing to confirm it once. So this has been our practice at our center. So as Dr. Divya said, since 2021, we are doing this NGS based MET amplification and exon 14 skipping and FISH based amplification testing for MET.
So thanks, Dr. Sushant, for sharing your experience. Now, can we move on to the next slide? Yeah. So now everybody knows now the biomarker, without biomarkers, no treatment is possible for the lung cancer. So biomarkers are not only used for the metastatic setting or advanced cancer. Now it has been used even for the early stage also. We have moved from the single gene testing by the PCR, FISH or IHC. Now more and more medical oncologists and the availability of the NGS technology is there across the India. And now most of the biomarker testings are done by the NGS. But given the scenario of the MET and the HER2, now we have to move back to the IHC. So my next question is to again medical oncologist Dr. Chandrakant, how comfortable are you to again send the test or the doing biopsy and the send the sample for the IHC testing, especially for the MET and the HER2?
Right, sir. So it is going to be challenging, sir, at least in majority of the places, because the tissue is an issue for us. So IHC, PDL1 IHC, ALK IHC, MET IHC, and I mean, so many IHCs we are in HER2 IHC. So I mean, the tissue gets exhausted, and after all these IHCs, we need to send the tissue for NGS. So it is both time, tissue, and resources. I think it is going to be challenging. Not easy. So unless and until you everybody has it in-house, that's fine. But I mean, like 80% of the institutions in India outsource NGS. So it is going to be challenging. And there are large randomized trials. In those trials, they have shown that 50% chance that the tissue is inadequate for all the 12 targeted genes. So if I exhaust tissue for IHC, it is going to be challenging, but I agree there is no other way. So we need to look at IHC, we need to do a FISH and then NGS. So it's cumbersome, it's cumbersome.
Yeah. So as you rightly pointed out that the tissue is an issue. Now, but even from our previous talk, Ms. Tasneem said that at least 29% of the patient who progress or develop the resistance on the third generation TKI at some point of time express the overexpression of the MET is there, and the drug is also available. And as Dr. Chandrika rightly said, there is a good overall survival and the progression-free survival by the savolitinib. So definitely the next era will be again going back to the IHC, and there will be the lot of requests from the medical oncologists will be coming for the MET IHC. So next slide. So again, now to Dr. Sushant. So he has just given his own experience and what the current practice and the standards they are doing at the TMC, and what in your current practice, Sushant, what cutoff do you use for the MET positivity, especially by the FISH?
Okay, so as we said, the FISH test is basically used for detecting MET amplifications. Okay, so there are two things that we note in FISH. It is the gene copy number. So the gene copy number cutoff should be more than 5 to call it as amplification. But we need to know that amplifications, since fish has been asked as a question, there are two sorts of amplification that can be there. One could be focal amplification, and then there could be polysomy. What I mean by focal amplification is that the MET gene or the adjacent regions around that gene has been amplified, or particular region has been amplified. And whereas by polysomy, I mean that the whole of the chromosome. So MET gene is present on chromosome number 7. So whole of the chromosome has been amplified. So if we see MET gene amplification is more important as compared to the polysomy, focal amplification is more important. So gene copy number of more than 5 is a cutoff. Second is MET gene by SEP17, that is centromere 7 probe. A ratio needs to be taken, and if that ratio is more than 2, again we say that there is MET amplification. But mind you, these are cutoffs that we are following at our centers. But if we go to literature, this is just an evolving practice that is there. There are different cutoffs that have been mentioned in the literature. 1.8 to 2.2 is considered as to be low amplification. 2.2 to 5 is considered as to be intermediate amplification, and more than 5 is considered to be high amplification by fish. So the clinical trials have used different cutoffs for calling MET amplification. So you need to establish your cutoff and stick to that for your practice, I would say, and then communicate the same with the medical oncologist who is practicing or who has asked the test.
Thanks, Dr. Sushant. So now again going back to the Tasneem and Dr. Minu. So as Dr. Sushant said, many centers also use the for the ratio between the MET and the SEP17. But in the clinical trial, whether the ratio was taken or only the copy number was used. Tasneem, your thoughts?
Yeah, so I couldn't actually hear the question. It was a bit mumbled for me.
Okay, so with the amplification for detecting the MET amplification, is the copy number helpful or the ratio between the MET and the SEP17?
Okay, it's the copy number.
Oh.
It's the copy number, and we have got a high cutoff at 10 plus gene copy numbers. So, the ratio doesn't really come into play then.
And Dr. Minu, your thought?
So we are using like ratio. Ratio if more than 2, then it is amplified. Like Dr. Sushant has told, the cutoffs are different. And if we use only copy number, then it is difficult to distinguish between polysomy and focal amplification. If copy number criteria we are using high, like 10, then it is easier to say that it is amplification. If copy number cutoff we keep 5, then it is difficult to distinguish between polysomy and the true amplification. So ratio in that way is better to be used for amplification.
Maybe Tasneem, that's why the cutoff has been used so high for the clinical trial to avoid that the polysomy issue. Maybe I right?
Absolutely. Yeah. Yeah. Initially, as you've seen from Protocol 6, it was a lower cutoff at 5 gene copy numbers, but then we increased it to 10. 10 gene copy numbers. Yeah.
I have one more experience to share. So we also use NGS to detect MET amplification on our DNA NGS-based sequencing. And so in NGS, we have not established any cutoff as of now. But we practice, I mean, anything if comes positive, we refer it to fish. And what we have seen is anything that has come as to be more than 6 copy number on NGS. Generally, the fish ratio met by SEP7 generally is coming out to be more than 2. So that is just, however, our case numbers, I mean, we have just used 4 cases yet to see this. So it's a very small niche experience that is there on NGS that we have.
Yeah, and I can add to that actually. So, we would love to include NGS into the strategy. We just know from the data so far that NGS tissue does, it's not as sensitive. You potentially would be missing patients. However, like I said, we are doing a number of studies, and I believe there will be some data coming out at World Lung Congress in September in Spain. So please do look out for that. That will be in the public domain. But what we are really pushing for is trying to get data with, on NGS instruments that can provide concordant data with fish, because we know that NGS, we talk about it a lot in NSCLC, the tumor types as well, and it's really a technology that's really taken off. So yeah, let's see where we stand with that and see what the data suggests. But do keep a lookout for that data from World Lung Congress in September.
Yeah. Thanks, Tasnim, for sharing your experience. So next slide, please. Next slide. Yeah, next slide, please. So this we know that now the MET is a part of a routine. At some given point of time, we need to test the MET while the patient progress on the targeted therapy. So we need to ensure that at any given point of time, we need to have when the fresh biopsy is available in the metastatic setting, at least we need to preserve the tissue for the MET and the HER2 IFC. So that's now also there in the NCCN guideline. Next. Please change the slide. Yeah. So again to to the medical oncologist, Dr. Chandrakant. So what your perspective, again going back on the IHC, so same thing what we have discussed. So are you, sir, comfortable for doing IHC or still you want to go ahead with the NGS?
So I think I don't have any experience of MET IHC. So there are new molecules that are coming up in this space. The Savannah study was one, and the other one is telisotuzumab vedotin. They look for c-MET as an expression. So any IHC is a welcome because it is easier and the tissue is upfront available. So it is great if IHC is correlating with response. It is great, can be done, but the problem is the tissue available for rest other markers is a challenge.
Okay.
As of now, no experience of IHC on MET.
Okay. And sir, do you use the MET testings or selectively, or you use for the all the patient who progress or who has a disease progression on the TKI therapy, sir?
Yeah. So we do NGS on all EGFR, ALK, ROS. These are the usual mutations who have a long progression-free interval on first-line therapy. And at progression, we always tell the patient to do a rebiopsy. I think 40% patients agree for rebiopsy. And then when we rebiopsy, we do NGS in these patients. So we are not doing any other IHC markers as of now on these. So that is, and we need to rule out small cell lung cancer. So this is what we are doing as of now. But as it was discussed before, IHC is becoming important. So we need to look how to figure it out right now. As of now, we are doing NGS.
Okay. But you will be comfortable for doing the MET testing once the IHC available, correct?
Yes, yes. The IHC is easy, can be done.
Yeah, and correct. Okay. So thanks, Dr. Chandrakant, for sharing your perspective. Next slide, please. Yeah. So as medical oncologists said that they are comfortable once the IHC is available for the MET testing, because it's not only for the those patients who progress on the EGFR anti-EGFR therapy or the TKI therapy, but it's also important MET IHC for those who progress on the ALK inhibitor or the ROS inhibitor also. So next slide. So next slide. So this we have already been discussed. Yeah. So now again to our oncopathologist, Dr. Divya and Dr. Aruna. How do you want to establish the MET IHC in your lab and the fish testing, and what the challenges you expect, and how do you want to overcome that? Dr. Divya?
Right. So I think for as far as IHC goes, it's going to be another new marker in an already, available sea of markers that we already have. So introducing IHC is not a problem at all. The question would be again, which platform? And many of us, I'm sure Dr. Aruna also must be dealing with multiple platforms. So we do have the DACO, we also have the Ventana. Now, as you say, the Roche Ventana SP44 can be introduced. It would need validation. It would need, familiarizing ourselves with the staining pattern, which I believe is a membrane staining pattern. And the scoring is 0, 1 plus, weak, 2 plus, moderate, and strong staining, 3 plus. So something like, HER2. So that should not be a problem to familiarize ourselves, what we are already familiar with. The things would be again, problems may come, but we know how to overcome them, which would be, standardizing it, validating it. And also there is an issue of heterogeneity, looking into that, and getting familiar with the scoring system, which would need some amount of, training your eyes, maybe a training, can be, we can do some online training programs. So I don't see it very difficult to implement MET IHC. The issue would be with the tissue. That's always the problem. I'm sure, like other IHC, this would also be amenable on cell blocks. So we can do it on pleural fluid cell blocks as well. Like other IHC, it may be difficult to do it on metastatic bony sites because that needs decalcification. So maybe we should not probably do it on those sites or necrotic sites. So those are the potential challenges and barriers. Outside blocks, in-house process samples where you're processing it in 10% neutral buffered formalin, you're choosing non-decalcified material, it's great. But outside blocks again can be, blocks coming from outside institutions can be a challenge with cellularity, etc. That can be a challenge. Dr. Aruna, if she has some points to add.
Yeah, I think, ma'am, you covered it. So the issue is that we do have the platforms already available. IHC is very simple to do. Problem would be in if there are any inter-observer variabilities, how easy is the scoring? And we might have problems with how to implement this IHC on other type of specimens, particularly cytology samples, which are not fixed in formalin. These issues might come in, but otherwise it should be fine.
Yeah, so to Jasmine, what's your experience regarding the IHC? Whether it's a challenging or it's a difficult like the HER2 or the any trouble regarding the pre-analytical factors or any specific thing we need to keep in mind before starting?
Tasnim, you're on mute.
Sorry about that. So like I said, the MET IHC space is a new space that we're going into. So, it is a little bit of the unknown, but from what we see and what we've seen in clinical trials, is that our MET IHC should be fairly easy and straightforward to score. I think why there's been a number of biomarkers, as we know, HER2, but also PD-L1 has been established sort of almost 10 years ago now. And that was probably the most challenging because it was a number of cutoffs with different clones. It was like calling it the PD-L1 mess. Now, off the back of what we know in pathology with HER2 and PD-L1 being the biggest kind of CDX markers, MET in relative to those will be fairly straightforward. In terms of cryo blocks, cell blocks, absolutely, we do understand that you're going to get a number of sample types from patients. Some less invasive methods. So we have seen that those samples should be fine in terms of MET IHC. But again, like we've talked about, standardization and validation in lab is absolutely critical to make sure that you've got standardized reporting, with the test itself. Again, like I've mentioned that MET IHC is a new space. We, such as AstraZeneca, in the future, and what we're doing right now is we will be providing courses together with, like, for example, Roche, who are supplying the antibody, online e-learning tools, even some face-to-face sessions maybe later on next year. but there'll be a lot of support providing these tutorials, how to score. But like I said, compared to PD-L1 days and HER2, this should be fairly straightforward, and I think there'll be less of face-to-face trainings because it is just fairly easy to score, with just e-learning tools that we have.
Yeah, thanks. Thank you very much. Next slide, please. So, as Dr. Sushant, do you have any tissue optimization strategy currently placed at your institute to make sure that patient can get done the NGS, FISH, and IHC all together for the progressive skin cancer?
So at our center, we have evolved over time. I mean, with molecular testing coming in, EGFR being the backbone of the molecular testing. After the histopathology diagnosis, IHC has been done, EGFR used to be done. Then ALK IHC, ROS IHC came in, and now we have totally shifted to NGS. So, as per the answer to the question, uh, we follow, I suppose Dr. Divya would answer it more better way. We follow one tissue in one block. So there are two blocks that are made. On one, HNE and IHC is done, and on another, the HNE section is taken, the tumor cellularity is assessed, and if the tumor cellularity is good enough for the particular molecular testing, then that block is taken up for molecular testing. So that is what is there that we practice. So Dr. Divya, if you could add on to this.
Thanks, Sushant. So we have a great MDT where we collaborate. That's the first important step, I think, whenever we are dealing with a situation where tissue is of limited availability. Of course, the radiologist comes in where he samples tissue which is not necrotic. We avoid using tissue which is from bony metastatic sites. That's next. We encourage also cell blocks for all pleural fluid, samples so that in case we don't have tissue, we have good cell blocks. Then the cold ischemia time has to be looked into. The fixation is very important. That is neutral buffered formalin is extremely important, how we prepare our formalin. We use the cores very judiciously, put them into, earlier we were using 3 blocks into 3 separate blocks, but now because of storage issues, we have now come down to 2 blocks. And the first block, as Sushant mentioned, is used for HNE and a very judicious IHC. We do not use things like CK7, CK20, CDX2 in all cases, very limited cases, only when we are suspecting a non-lung site for certain reasons. Otherwise, a very limited panel of TTF1 and P40 and maybe a special stain, very, very limited fashion. We don't take deeper sections to lose tissue. So HNE, judicious, special stain, very judiciously use IHC, do not take deepers, leveling we don't do. The other block, we keep it for molecular testing. We write the cellularity very accurately on our blocks, and we specify which block is to be used for molecular testing. I also want to mention the storage of tissues, which is very important, how we store the paraffin blocks in a cool, dry environment, extremely important. And of course, this process is an ongoing teaching process. We have to constantly retrain our technologists, retrain our fellows as to how we want to, take this message down that tissue is extremely precious and optimization is key in this era of precision medicine. So these are the few steps that, we follow at our medical center.
Dr. Divya, sharing your experience. Yeah, next slide, please. So this is to the Dr. Chandrakant. Sir, now every week or month, the new drug and the new molecules are coming in the market. So what are your expectations from our pathologist community, how to incorporate the new molecules in the routine testing guidelines, sir? Dr. Chandrakant, sir.
I think I can see Dr. Chandrakant.
Yeah, so again, Sushant, to you. So, what's our role or our job when the new and new molecules are coming every week or every month, and the new drugs and everything? So, our community should do, and how to collaborate with the medical oncologists and the drug companies to make sure that we keep ourselves updated with the recent guidelines and the recent testing methodologies.
Yeah, so as I previously mentioned, even before coming to this webinar, I was not aware of Met IHC use that is there, and NCCN has actually incorporated it in the guideline, and there is an ADC available.
Yeah.
Difficult name, I think, for me to pronounce it. But yes, I mean, if we see the scope of targeted therapies is increasing, not just in lung cancers, in all other cancers also, and keeping oneself updated with the current guidelines is very important, and keeping oneself abreast with what pharma companies are developing new and what new targeted therapies are coming, that is also very important. And coming to the pathologist front, we need to be able to judge and be able to pick up tests which would be rightly able to detect the biomarkers and provide results to medical oncologists so that they can utilize it for the betterment of the patients based on the scenario that is available. So yes, slowly and steadily we are going into an era where everything is getting personalized, and for not just lung, all basically cancers, we will have some biomarkers coming up, which would be important. So, as pathologists, we should be abreast with the new knowledge, keep ourselves updated, try to know the advantages, disadvantages of the different modalities of tests that are available, and which particular test would address the biomarker and the therapy that was available.
Yeah, Dr.
That would be from my side.
Yeah, Dr. Aruna, your thoughts on that?
My thought is that we have to start with MET IHC testing. This was primarily be an add-on to what we already have. We would still need to continue fish testing, and NGS, of course, will have to be done in all these cases. So in this, the question would be, how are we using this tissue that is available in a post-TKI biopsy? Whether I do IHC first, followed by fish, and then an NGS, which will eventually be required anyway. So the selection of the appropriate testing methodology should be based upon the center, what type of facilities they already have, and the expertise they have. If they're comfortable with fish, and then IHC can be started off, and then we will need to develop our own data to see which is working out. And of course, at the end of the day, cost effectiveness also is an issue. We need to see how many more tests we can keep doing. Give the clinical information for the patient's therapy.
If I could add one more line to the second question, how would you select appropriate testing methodology? So at present, I would say that NGS is the frontline testing methodology for lung cancers, because NCCN as well as ISLCs and AMP guidelines suggest a broad panel to be taken into consideration. Now, with newer guidelines coming up, wherein MET overexpression needs to be studied, since a targeted therapy, specific targeted therapy is available. So, what I see going forward is, as Tasneem also highlighted, NGS would be taken up. If NGS comes out to be negative, and at present, if the patient is advanced, progressed lung cancer patient who has received osimertinib as therapy, first line therapy, and still has progressed, in that cases, we can take up MET IHC to check for overexpression if available. And of course, availability of drug needs to be the most important thing to be taken into consideration. I mean, if the drug is not available, even if we test it, it's of not use. So using appropriate testing methodology is very important at present.
So, Tasneem, your thoughts on this? NGS versus IHC versus fish, what do you prefer?
Yeah, absolutely. So I really, really liked Dr. Muyang's kind of perspective because, there's a lot more that goes into the mix, and what we uh, probably have a global strategy for when we launch is probably very different to what actually happens in the real world. And I'm definitely more connected to the real world than probably global strategy. So let's take a look at the clinical trials. I think I always go back to the clinical trials, how the patients were identified. Because if we're looking at the efficacy and the data from the clinical trials, we need to be able to replicate that in our local patient population. So in this particular place, I would definitely say IHC and fish will give the patients the best optimal chance and treatment options. But of course, I know that NGS is utilizing NSCLC, and we need to incorporate that within the workflow. So like, you mentioned earlier on very beautifully, it does depend on reimbursement, how much tissue you've got, do you have the drug, do we do NGS first? And there's no, I think someone mentioned it in the chat actually, that if there's no actionable mutations through an NGS panel, you then do an IHC in a fish, that sounds fine. I mean, we're not here to kind of dictate what each institution does, because it varies, immensely. I think there's one message for me is that if you're looking at resistance mechanisms for MET overexpression and MET amplification, IHC in fish somewhere needs to be incorporated into your workflow, especially if there's no other oncogenic driving mutations in that setting. So you just need to kind of be cognizant and be wary that, these are patients that would respond to this treatment, and they're identified through IHC in fish. And I think, again, and I can talk a lot, I think the fact that IHC is cheap, it's decentralized, it's in a lot of institutions. And I used to work in the Middle East region and that kind of Asia region, so I do understand the limitations, and I do believe that this is quite a good test, like the IHC in the fish, for institutions where NGS technology is limited. So and again, it varies across the board, and in India, it's very mixed archetypes. Some sites may have, state-of-the-art technologies, whereas other will kind of have back to basics, which will really, really understand. So important thing is IHC in fish needs to be incorporated somehow into the NGS, I think.
Yeah. So, so next slide, please. Okay. So, from all the panelists, we would like to have their own perspective from this, because this is the first topic and the first time in the India we are discussing the MET in the NSCLC. So, what the take-home points from the each one of the panelists, that everybody should understand that, okay, how do we progress and how do we go about the MET testing in the future, and how can we can able to incorporate the MET testing in our routine diagnostic practice. So with Dr. Sushant, your thoughts on that, your take-home points?
So, I mean, if you're looking at on perspective of MET alterations, the two most important alterations are MET exon 14 skipping mutations. Again, there are different methodologies to target this alteration. NGS is the most important one. Sanger sequencing, RT-PCR are also tried and noted in literatures. But if you are looking at MET exon 14 skipping mutation, IHC will not be able to detect this. I'm sure. I have not studied how IHC is actually working, but MET exon 14 skipping mutation actually leads to, I would say, loss of degradation of the MET receptor. So indirectly, the MET receptors increase in number. So probably IHC might, I would say, a second way, be detecting MET exon 14 skipping mutation. But to document this, NGS is the best modality that is available. MET overexpression, now there's nothing, no question left about it. Again, IHC is the most important test for this. So, looking forward, NGS and IHC would be the most important modalities for MET alterations. Cutoffs, again, we need to see how the cutoffs have been followed in the clinical trials, and which would be the best efficacious cutoff so that the best response from the treatment comes. That needs to be followed. taking the MET overexpression IHC into consideration.
Yeah.
Tissue optimization has always been a issue with lung cancers. The biopsies are small. The tumor cellularity plays very important role in the treatment methodologies that we apply. So yes, tissue optimization is very important. So a diagnosis on HNE, IHC, then a broad panel of tests, biomarkers that are there, and then we need to preserve tissue for the emerging biomarkers that are further coming our ways. MET overexpression being one of them.
Yeah. So, Dr. Minu, your thoughts, cutoffs, 5, 10, or this ratio?
So I would like to add, like previously Dr. Tasneem told copy number and I told ratio. So I think that there is a need for more guidelines like HER2 fish testing in breast. We are doing right, left, and there are many guidelines. ESCO is updating the guidelines. So that reporting is in correlation with the fish and IHC both. So if the ratio is more than 2, then it is more, and copy number is more than 4 of the MET. Same in the HER2 reporting, it should also be updated so that we can report as positive in correlation with the IHC. Because in HER2, if copy number is between 4 to 6 and ratio is not more than 2, then they fall in group 4. And likewise, if copy number is more than 6 and ratio is not more than 2, then it falls in group 3. Then reporting is done in correlation with the IHC, because if protein expression is there, then only the drug will work. So likewise in lung MET also, we need to have more refined guidelines for reporting in correlation with the IHC, because both are important, ratio as well as the copy number. If copy number is more than 6, 7, then there is amplification, and if ratio is more than 2, then also amplification. But guidelines are there is a need for more refinement, that I feel.
So again to the Tasneem. So regarding the severity, so we just stick to the drug and the Savannah trial. So for this trial, what are the cutoffs and what is the guideline? So still we know that this guideline is not there in the NCCN and not there in the CARE ESCO also. But for the drug trial purpose, what the pathology should follow?
Yeah, so good point. So I do agree with you, Dr. Minu. Guideline bodies will be updating. Should I say that NCCN have just updated in May? I think Tilly was launched like a few weeks before that update. So the guideline bodies will move with us. So yes, we are working very closely with ISLAC as well. So ISLAC, ASCO, NCCN, all the key guideline bodies will and should have these updates for fish as well. So at the moment, let's just focus on IHC because we've talked a lot about fish and primarily the strategies, as you've seen earlier on, IHC identifies MET overexpression and it's the most sensitive. You'll identify a lot more patients with IHC, 29%. Now, fish, we've incorporated that into the strategy to give laboratories and hospitals an option. So some labs may not want to do IHC, they want to do fish. So that's the reason. But if you're doing IHC, you're more likely to identify those positive patients and you're only deploying fish for those IHC negative patients. You really want to get every opportunity and that chance for that patient to get that therapy. So if IHC is negative, we then put them onto fish. So again, I do agree, guideline bodies do need to include this, and there will be more guidance on gene copy numbers and ratio. It's just that this is a new space. And that Tilly that was launched with just MET IHC. They did not incorporate fish into their trial. So that's why we've not got any kind of data or any guidance on that. But so we are the first to go in with fish, and you will see that. I can promise you that. Just a few comments, just as I finish off on the question again. I think my key takeaway messages for this question is, I think prior to Savannah and Saffron trials and MET overexpression and MET amplification, when we mentioned MET testing to a doctor, and we'd say, "Are you doing MET testing?" They were like, "Of course I am. and then he'd be like, what are you doing? And he was like, I'm doing Met exon 14 skipping. So I think previously, if you turn back the clocks to 6 months, 12 months, if you talked about Met, it was, yeah, I'm doing it. So Met before was by default, no, Met exon 14 skipping was by default known as Met. Now, today, I think we need to revisit that language. When we talk about Met now, we need to call out and say, actually, are you doing Met testing, overexpression amplification, Met exon 14 skipping? So that's the kind of question we need to kind of dive into a little bit deeper because there's 3 different types now. So when I first started to work on this project, and I was working on this at the Roche side with the tissue diagnostics experience, and I was really glad that Met testing was established for Met exon 14 skipping. But I think it's hard work, kind of retraining that brain. Met's not just about exon 14 skipping anymore. It's actually Met overexpression amplification. Whereas sometimes when you come in with a completely new biomarker, you can say, this new biomarker is established now, so start testing for this. Whereas now there is going to be that kind of confusion with doctors saying, yes, I do test for Met exon 14. And it's the same as Met overexpression amplification, and they are not. They're different in their modalities, they're different in terms of prevalence, and they're different in terms of testing technology that needs to be deployed. So I just wish, if I had a magic wand, that I could rename Met into another biomarker because there was going to be some confusion.
Yeah, so Met is not only the exon skipping, it's amplification, it's overexpression. Maybe now it's also there is a hot topic regarding the focal amplification versus the polysomy also, because that impacts the overall response to the drug also. Because many times we know that the Met is a redundant driver. It's if you see that the Met, it's the downstream pathway are the MAP kinase pathway, the RAS pathway, the PIK3 pathways are there. So it's not always that those all cancers which has a MET overexpression or amplification, they respond to the MET directed therapy, because there are other mechanisms also may be available. So maybe I am right, Tasmin?
Correct. You got it.
There are so many cancers which has a MET overexpression. If you see the colon cancer, renal cancer, thyroid, but not all have a MET directed therapy.
Correct.
Yeah. Dr. Aruna, your thoughts and takeaway points from this session?
Yeah, so yes, I think we will have to start looking into how we would start testing for MET overexpression as well. And I'm hoping that in the coming days, we'll have more information on what should be the clear cutoffs and testing strategies, what to do first, what to do later, those sort of things. I hope with more information coming in, we should be clearer on that. But the first step would be to basically start doing it.
Dr. Divya?
We've conquered PDL1, so I think Met IHC shouldn't be a problem. The cutoff seems fairly straightforward, like they're saying 3 plus and more than 90% cells. Here we are looking for that 1% and 1 cell and immune cells. So I think, with our experience with HER2 and all the IHCs that we have, this shouldn't be a problem. But a new marker is a new marker. We will see when it comes. As Dr. Aruna is saying, we let the drug come in. We are happy to e-learn, e-train, and take it forward.
Yeah. And Chandrakant, are you there? Okay. So maybe that's the end of the panel discussion. So thanks all the panelists to share your experience and your thoughts, because that's the first time we are discussing met in the NSCLC in India. Maybe that's the stepping stones, and that's the thanks for all of you to share your experience, so that you can start the MET IHC and the MET fish as soon as possible in our lab. Dr. Sushant, over to you.
Thank you, Dr. Milap. Thank you, Dr. Milap, for the panel discussion, and thank you to all the panelists for this wonderful discussion that we have. And now we are about to conclude the session, and we were supposed to take question and answers, but I suppose while the panel discussion was going on, Tasneem has answered almost all the questions, and no questions are left. I can't see any questions pending. So thank you, Tasneem, for taking the questions while answering the questions of the panel discussion as well. Uh, so I would like to thank Molecular Pathology Association of India for providing this platform for discussion on the MET alterations in non-small cell lung cancer, and has been addressed by Tasneem, Dr. Milap. This is for the first time probably in India. We are having a webinar on MET alterations, and I'm sure this webinar and the educational event will actually help all the medical oncologists and the pathologists who have attended this. And my sincere thank again to all the faculty members, Dr. M.V. Chandrakant, Dr. Divya Mida, Dr. Aruna Nambirajan, Dr. Meenu Angi, and Tasneem for having this session with us. And with this, I would conclude the session. Thank you very much. Thank you, everybody, for attending the session.
Thank you, everyone.
Thank you.
Thank you.
Thank you, everyone. Bye.
Thank you. Thank you.
Thank you. Bye.